Okay. Good morning or afternoon. My name is John Barrows. I am the President and CEO of the International Eye Foundation, and it is a pleasure to be the chair of Vision 2020 USA. Vision 2020 USA is a member organization of 48 organizations with a common interest in promoting vision and eye health in the USA. I want to begin by first thanking our members who have sponsored this year's event. Your contribution is highly appreciated. Today we celebrate World Sight Day. World Sight Day is an international day of awareness held annually on the second Thursday of October or thereabout to focus on the global issues of avoidable blindness and visual impairment. Every year, Vision 2020 USA conducts a congressional briefing as a moment to highlight topics on visual health that are important to our organizations, our beneficiaries, our collaborators, and government officials. Today's topic is diversity, access, and eye care, which we all care about very, very deeply. We have two excellent speakers, Dr. Kevin Frick and Dr. Joy Harewood, who will deliver insight into concepts and clinical realities on diversity and access in eye care. Before we begin, we encourage the audience to submit questions using the chat box feature, which is found at the top of your bar, I believe, or the bottom. It says chat. Your questions will be addressed after the presentations in the Q&A session, moderated by Dr. Jennifer Cook. In addition, we are recording the presentation and will post it on the Vision 2020 USA YouTube channel. To begin, I want to introduce our first speaker. Dr. Kevin Frick is a health economist who has been on the faculty of the Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins Carey Business School for more than 25 years. He has contributed substantially to the literature on the economics of eye care and the literature on variation in utilization. He is currently working on teaching, research, contributing to the discussion around the economics and utilization of eye care. In addition, Dr. Frick has presented at World Sight Day events in the past, at least 2 times, I believe. Dr. Frick, please proceed. I'll mute myself and I'll unshare my screen.
Thank you, John. Let me share my screen and we can go from there. All right. Great. Well, thank you for the introduction, and I am pleased to be speaking to this group this morning about diversity, access, and eye care, concepts, and clinical realities. And when we think about this topic, there are a number of terms to define to make the concepts clear even before we begin to think about the policies, the politics of getting to some of those policies, and the clinical realities that my colleague, Dr. Harewood, will focus on. So today, we're going to begin by talking about diversity and access, and think about how these relate to care before we hear about some of the clinical realities that will help us to understand how optometrists and ophthalmologists are reached by those who need eye care in general, and then the specific issues that may arise for members of diverse communities. So with that, let me begin by defining diversity. Diversity has many definitions. One of the first things that we might think about when we consider diversity as it relates to healthcare is the combination of issues around race, ethnicity, and national origin. When we think about those in relation to access to care and access to eye care particularly, the key is whether there are barriers to access for individuals who are not originally from the United States, or for individuals who are in a minority or otherwise marginalized community within the United States. Now, this isn't to dismiss the responsibility of individuals for getting care when they have good access, and there's recommended care that people should be getting. But the key is there are many individuals in the United States for whom access has barriers. And so we have to ask, what are those barriers? Are there specific barriers that are particular to a population that we could focus on, and how we could change those barriers through policies, through initiatives by private organizations, and changing how they do business to do business more with the humanity of their community and their patient population in mind. Now, before we talk about the subtleties of access and the potential for policies that might alleviate some of the barriers that exist for those in minority or otherwise marginalized communities based on race, ethnicity, and national origin, it's also worth considering whether there are other personal characteristics and demographic characteristics that are associated with being marginalized and that should be considered for potential policy initiatives. Now, different organizations have suggested very different ideas of what diversity can mean. My own university has a diversity wheel, which you can see on this slide, and it's worth thinking about all of the different categories that are on this diversity wheel. So as we look, we start with, race and ethnicity, which are in one category, national origin, which is the second. And as we look at the whole wheel, we can just go around education, political beliefs, family, organizational role, language and communication skills, income, religion, appearance, work experience, age, gender and gender identity or expression, sexual orientation, and with particular importance when it comes to vision, mental or even more importantly, physical abilities in terms of people's ability to get care, to get to care, and think about all of these things. Now, for some of these, potential barriers that are associated with these may be more obvious. Income is one, language and communication skills may be a second, and physical ability to get around may be a third, all of which can be important as we think about ways in which people can or have barriers to accessing care. There might be other things here where it could be more difficult to think about, well, how would that possibly relate to access to care? Maybe political beliefs, maybe appearance. The key is when we think about diversity, it's worth thinking quite broadly and thinking about all the ways in which variation based on these characteristics could change how we treat one another. How is the patient treated differently by an optometrist or ophthalmologist? Hopefully not at all. But are there things that will vary depending on any of these characteristics? And how does a patient with these characteristics see a provider who shares or does not share these characteristics with the individual? All of these things are worth considering as we think about how individuals with any set of demographic characteristics go about getting care for themselves when they need eye care. Next, we think about dimensions of access. And when we think about access, a lot of people would start with affordability. Happens to be in the lower left corner of this framework with 6 dimensions of access. But affordability is, again, just one element of ways that people in health services research and health policy have conceptualized access over time. Of course, when you ask people, why aren't you getting eye care? A very frequent answer is lack of insurance or cost. And so we can't ignore affordability. And affordability is likely to be associated with some of the categories we saw on that last slide. Affordability has to do with income. Affordability has to do with insurance. Affordability may have to do with work experience and age, or even gender and education. All of these things are quite important. We may find that eye care professionals have offered free services for communities and people still aren't accessing care. So the key here is to remember affordability is a necessary but sometimes not sufficient condition for encouraging people and facilitating people to utilize eye care. And utilization is realized access. First, we have to make sure that individuals understand that the care is available and where to get it. Then we can ask, are they using the care once it's there? Of the other 5 categories on these dimensions of access slide, the next one that people often think about is the concept of accessibility, which is simply, do the services exist in a place that people can get to? And when we think about this, it's not just, are they there, but what about the transportation? And what about the time and the cost of transportation? I'm not sure whether it's made national news, But I know locally here in Baltimore, there is right now an effort to assess how accessible different parts of the city are based on transportation in certain communities. And not surprisingly, the communities that have a harder time reaching parts of the city tend to be lower income and minority. Why is that? We're a city here where there's an enormous number of bus lines that don't coordinate very well, one subway line and one light rail line. And if you need to, while anyone who lives within the city limits is within a 10-mile trip of, say, Wilmer at the Johns Hopkins Hospital, for some people, like me, it would be an easy 20-minute drive, maybe 35 on a day with lots of traffic. For other individuals who have to take one or a series of two buses, or a bus and one of the rail transportation formats, it could easily be more than an hour and sometimes almost two each way. So in addition to the time that such an individual would spend waiting for their appointment at Wilmer, and in their appointment at Wilmer, they could easily lose between a quarter and a half of a workday just getting to and from the facility. And so accessibility is quite important in terms of the existence of the services and people's ability to get to them. Now, those are two, fairly straightforward things. Are the services geographically accessible and are they affordable? But beyond that, we really think about whether or not there's enough supply of services just because they're there. And that's the concept here of availability, matching supply and demand. You might have a facility like Wilmer, but if people are demanding twice as much eye care as is available, the simple fact that it is geographically close by doesn't mean that it's easy to get to. And when we think about this aspect of care, it can also be the fact that if there's much more demand than there is supply, it can limit the ability to get care in a timely way, which is important for a variety of eye conditions. So those are the three sort of easiest ones: simple price, geographically accessible, supply and demand. Now, as we think about the other three dimensions, it's important to recognize that in many cases, we've thought about access to care as a matter of the fit between the patient population, their eye care needs, and the providers of care. And when we think about fit, is it a good fit or a poor fit? That's where the other three dimensions really fit in. So first, we can think about the dimension called accommodation or adequacy. Accommodations is things like, how easy is it to schedule an appointment? If you call on the phone and you try to schedule an appointment, do you wait on hold for a long time? For populations that have easy access to electronic scheduling and electronic access to scheduling, is that an easy system or a difficult system to use? What are the hours that providers are available? And how long does it take to get an appointment? There are many times when it can take 3-6 months to get an appointment if you're a new patient. And that would be a challenge with accommodation in that case. Accommodation can also be a matter of whether or not someone who has a physical disability can easily get to the care site. So we can't forget about that issue. The next element I'm going to touch on is acceptability. Do patients find the providers and the facilities acceptable? So a patient may want to see a provider who is demographically similar to themselves. If there are no providers like that, does that inhibit patient's ability to feel comfortable getting care? Of course, we would like to think that patients could get high quality care from any provider, but if it really matters to the patient to see a provider who is like themselves in some way, then that's an important consideration. Those were the original 5 dimensions that were as part of this framework. More recently, there was a 6th dimension added, and the 6th dimension is awareness. Awareness is an interesting dimension for this framework because it focuses both on the patients and the providers. Are the patients aware that the services are available? Are the patients aware of ways that providers have tried to make their services more affordable, more accessible in terms of times of day? Are they aware of what is recommended for eye care for them, whether they have a condition like diabetes or whether they are just a general patient? And then, importantly, are the providers also aware of the needs of the particular patient population that is closest to them. So 6 different dimensions, again, much more than just is the service there and is it affordable? And as we think about ways that a population of patients who are trying to maximize lifetime eye health and lifetime visual function as a way of enabling themselves to participate in society in ways that make them most comfortable and facilitate their success, not that they can't participate if they have a visual disability and find ways to accommodate that. But if we are trying to maximize eye health and visual function for a population, sometimes we're going to have to think about things that go well beyond just decreasing the price, adding insurance coverage, even mandating care in order to get people to use care. And it's very important to understand how all 6 of these dimensions are relevant to a population and a provider when we are planning for a change in government policy, an initiative by a private corporation, an initiative by an individual provider, or an initiative even within a community trying to figure out how to help its own community members. Now, it's worth then thinking about a few very specific examples. I've drawn just a couple examples to illustrate what are barriers that are associated with diversity characteristics. So here's a paper that is obviously very relevant in the now. This is Kanza Aziz from Johns Hopkins and colleagues elsewhere in the United States. And this team looked at the association of patient characteristics with the delivery of ophthalmic telemedicine during the pandemic. What they found is that patients who are men, identify as Black, have an educational level of high school or less, and do not speak English as a primary language, were less likely to receive telemedical care during the pandemic. That actually is very important because telemedicine was the way that for quite some time was the only way you were going to get much other than emergency care. And these are important diversity-related characteristics for which people were having difficulty accessing care. And that difficulty could come from a lack of access to the technology, a lack of income even to have the technology available to them, or challenges with using the technology in some cases. Michael Firm from Baylor and his other colleagues around the United States looked at clinical and demographic factors associated with diabetic retinopathy among young patients with diabetes. Here, again, finding Black or African American race found to be associated with diabetic retinopathy in the univariable analysis, but not in the multivariable analysis. And so they suggested that race or ethnicity may be correlated with access to technology to control diabetes and diabetic retinopathy. So sometimes, especially when we look at multiple variables together, an association that looks like it might begin with one diversity characteristic might actually be a function of other characteristics that go alongside and are correlated with it, in this case, income and access to technology. If we look at the study by Brittany Brueggemann from the University of Florida and her colleagues, barriers to retinopathy screening in youth and young adults with type 1 diabetes, older participants, those with a longer duration of diabetes, were more likely to report barriers to screening. Interestingly, sex, race, and ethnicity were not associated with reporting a barrier in this case. So race is sometimes associated, but not always. Here, the biggest concern might be economic issues around missing school or missing work. Just a couple other examples. Angela Elam from the University of Michigan and her colleagues looked at disparities in eye care utilization, and they found that disparities existing in how patients accessed eye care, particularly looking at whether it posed a high mortality risk. And then in their affluent population, there is a trend toward non-white patients being less likely to access care. So while telemedicine helped, again, there were issues of broadband and getting people care. Next example, Olivia Colleen, also from the University of Michigan, looking at barriers and facilitators to obtaining eyeglasses. The main barrier was cost, negative experience with eyeglasses, and limited access to care. Top facilitators were positive experience with eyeglasses. Key question is whether online, which was recommended, would solve the problem. And again, then who in a diverse population does or does not have access to online services? Rasandran et al. From Case Western looking at demographic and socioeconomic differences in outpatient ophthalmology utilization, found that Hispanic and Black patients had fewer outpatient visits than their non-Hispanic white counterparts. Again, interesting interaction here of demographics, types of care, who's accessing what, whether it's eye care in general or emergency eye care, and the expenses. Just to illustrate issues with diversity. 2 older studies, disparities in utilization from the last decade among visually impaired US residents varied significantly by race, ethnicity, and income. So the problem is not new, not new rather than now new. My apologies for that mistake. And then Shinji Zhang, looking at again data from a decade or 2 ago, found that race is not always associated with differences. So to conclude, just a few ideas for how we might approach trying to find solutions to dealing with a diverse population and trying to facilitate equitable access to care for the diverse population to use. One thing that we might think about is the coordination of care. And we can think about optometrists in a primary eye care role, specialty eye care, and how primary and specialty eye care interact with primary and specialty health care as we think about making sure that people are in the healthcare system in general, that patients with systemic conditions that correlate with eye conditions can get referrals from their general physicians to an eye care specialist, or if there is a ocular manifestation of a systemic condition, how to make sure that there is a clear system for referrals from the eye care world back to the general healthcare world. And so thinking about that is one way to promote access to eye care. And then finally, what are the policy levers that we have? We can think about public health ways. We could think about financing of care. We could think about communication of care to the population. I mentioned public transportation, particularly within the access and accessibility feature. We could think about the eye care workforce. How do we make it either bigger, if that would be helpful, or look more like the patients who they are trying to serve? How is healthcare organized and eye care organized? And particularly, are there ways of pulling eye care into more general care provision, such as with the federally qualified health center? The care coordination I just mentioned. And then are there not-for-profits or other businesses who view this as part of their corporate social responsibility to try to make eye care more accessible and equitably accessible to diverse populations? With that, I'll say thank you and turn it back over to John Barrows.
Thank you, Dr. Frick. That was excellent. And for your attempt to unravel such a complex problem. And I should also note that for many of our members who work internationally, it's very similar types of problems. So thank you very much. I want to introduce the second speaker, Dr. Joy Harewood. Dr. Harewood is the inaugural Director for Diversity, Equity, Inclusion, and Belonging at the SUNY College of Optometry, where she holds the title of Associate Clinical Professor. She also has extensive experience in hospital-based eye care, and as a clinician and educator, she has been a leading voice in the push for diversity, inclusion, and equity in the optometric field. It is a pleasure to have you join us today, Dr. Harewood. Please proceed.
The muting tool might be towards the top of your screen now. The toolbar moves as soon as you share. It's sneaky like that. Is it not showing up towards the top of the screen where you can... and I can't unmute you myself, unfortunately. Oh, I see you moved. Oh, I sent you a request to unmute, I see. Yeah, generally towards the top of the thing. If it's not there, then the little thing will drop down, and then you can mute and unmute, and then stop your video and all that other good stuff. Okay, I guess we could stop sharing and then unmute and then share. Maybe we'll have to do it in that order, just so you can have the regular screen pop up.
Can you hear
Okay.
me now?
There we go. Okay, and now go
Good.
ahead and share. That's sorry about that. I don't know why it hit
No
everything
worries.
from you.
That's fine. Excellent. Am I sharing now? Yeah, great.
Yep, looks
So
good.
thank you very much to Vision 2020 for inviting me to speak today. And thank you to my colleague, Dr. Frick, for going through all of that information. What I'm going to do is bring it back to the patient and personal level to try to explain how access or how we lose access and access to care in order to provide for our patients and the barriers that may be created. And to give you a little bit of an idea of what has made me so interested in access and why access is something that's central to the way that I practice, is really to start with my own heritage. This is actually a picture of my family in front of our home in Antigua. It is World Sight Day, which is a global day of awareness. So I definitely wanted to bring in something about that. And this is a picture of my mother. She's the bottom left, as well as 8 of her siblings. One is missing. Now, I show this picture because there are actually most of the people in this picture who are visually impaired, secondary, a lot of the time to of lack of access to care. In a country like the US, where there are a lot of resources, one can imagine it may be easier to overcome some of these barriers in access. A country like Antigua, it would be somewhat more difficult. I think that gives us a little bit of hope in the sense that if we have the resources, the know-how, and the knowledge, we really have the ability to overcome some of these barriers. In terms of my own clinical practice, I'm in New York City right now and I practice mostly in medically underserved areas of the city. Initially, I practice in areas of Staten Island. People don't necessarily think of Staten Island as a diverse place, but it actually is. There's a lot of West African people, a lot of people who have varying levels of access to care. With a lot of people who are unable financially or otherwise to access care. The other place where I spent a lot of my hospital-based care is in the South Bronx, Congressional District 15, actually. And this is one of the poorest, if not the poorest, congressional districts in the country. We definitely had lots of issues when it came to access, not just affordability. I can tell you that in terms of my own eye appointments, often people are waiting for me for 4 to 6 months for a routine eye examination. So I'll work through that with that lens to give you an idea of how access affects patients that I've seen, and I'll go through some patient cases. I'll separate it by the A's of access that were described before, just so that we can directly relate. And finally, I'll go through maybe some recommendations that from a clinician and patient standpoint may be useful in tackling these barriers. So first thing is affordability. And as we know, that's determined by how the provider's charges are related to the client's ability to pay and willingness to pay for their services. The first picture I'm going to show you is of a fundus. For those of you who don't look at these all the time, this is the back of the eye, this is the retina. You can see the optic nerve is a little round thing in the middle. And this patient has a lot of bleeding in the back of the eye. The patient is actually a Black woman in her 40s who I was introduced to maybe in my first or second week of practice there. When we met, she'd been diabetic for several years, but she confided in me that although she was fully employed, She'd been unable to afford insurance for several years. That meant in the intervening years, she was trying to control her blood sugar with a variety of diet, exercise, and home remedies. But she'd been unable to access the oral and injectable medications she'd been prescribed. We are well aware that diabetes does not affect all races and ethnicities equally. Data from the American Diabetic Association shows that the rate of diagnosed diabetes is much higher in non-Hispanic whites as well as non-Hispanic Blacks than the general population. In 1998, Beckles et al. Showed that uninsured patients with diabetes are less likely to access preventative foot and eye care, as well as other healthcare services that may prevent them from having these, morbidity when it comes to their eyes.
Dr. Harewood, I hate to interrupt. It sounds like it's a little muffled on our end. If you could just speak up a little bit, it might be like a bandwidth issue for some reason somewhere, but if you could just speak up a little bit, okay, that might help us. Thanks.
Does that sound a little better?
Yes, that sounds good.
Okay, wonderful. Definitely let me know if you can't hear me, okay? So as I was saying, Beckles et al. In 1998 found that uninsured patients with diabetes are less likely to access preventative foot and eye care, as well as other healthcare services that can help them not get to these more severe stages. As I was saying, diabetes ravages the small vessels of the body, causing neuropathy, nephropathy, as well as retinopathy, as we're seeing right here. Now, she'd been bleeding into her retina for years, her vision slowly getting dimmer and dimmer, unable to do anything to tangibly stop that decline. When the Affordable Health Care Act of 2008 was rolled out, she was finally able to access care. And she jumped at the chance to see her podiatrist, her primary care doctor, and yes, eye care. That was myself, and I was able to refer her to the right place in order to treat her disease. By that time, she did have some visual impairment, but we were able to intervene at a stage that she was able to see adequately to do her activities of daily living. She was forever grateful for the ability to access care. And I mention this just to say, although I am going to speak about the other A's of access, it's very important that we protect and push through manners of increasing insurance and access from a financial standpoint for these patients. The next A would be accessibility, and that refers to geographic accessibility, which is determined by how easily the client can physically reach provider services locations. So this is another picture of the back of the eye. It looks likely, if you took a look at the last picture, a little bit more severe in its presentation. I'm going to speak about another diabetic patient who had much more severe disease than the patient I spoke about before. He was actually a white male in his late 50s who had had Medicaid services for years. I saw him because he had been admitted to the hospital due to severe complications of diabetes, diabetic ketoacidosis to be specific, as well as highly elevated blood pressure. Now, in order to properly treat his disease, he had to use insulin and he had to attend regular eye care services and other services to better access care. Although he was completely covered and he had the financial wherewithal, he lived in an area of the island that did not have an accessible bus route. Transportation to and from the clinic was a huge issue. In terms of the housing that he could afford, there were many steps that acted as a physical barrier to him even leaving the house. By the time that he was seen in my service, he had the most severe stage of diabetic retinopathy, proliferative diabetic retinopathy, and he had so much bleeding into the back of his eye that he was really unable to see. So when you're unable to see, it's not just that you can't get around, you can't administer your own medications. So we're telling him to use insulin, but he's not able to see well enough to even do so. So Lee et al. And Boyle et al. Both found that in urban settings, less geographic proximity to eye care facilities and poor quality of public transportation is associated with lower levels of adherence to recommendations for dilated eye exams in patients with diabetes without a diagnosis of diabetic retinopathy. Transportation interventions like travel vouchers and arranged transportation may have a significant effect on the detection of diabetes as well as the treatment expeditiously. So this patient, thankfully, we were able to actually, while he was admitted, clear some of that bleeding out of the back of his eyes. So at least he would be able to administer the medications that would really be sight and self-saving. The next, availability. The extent to which the provider has the requisite resources, such as personnel and technology, to meet the needs of the patient. So this is another patient, diabetic, type 1 diabetic patient in her 30s, who came into my office just for a regular diabetic retinal screening. You know, she was one of those patients that when she came in, she wanted, you could tell she wanted more than just the eye examination. So I took a look at her eyes and made a note to myself that perhaps I wanted to inquire a little bit more about what was going on with her. After I finished her examination, it was clear that she didn't have any active retinal disease, but it also was clear that she was a survivor of domestic abuse. She told me she had immigrated from Tunisia several years ago and been promised many things by the person who helped her immigrate that she did not get when she got there. The person had become somewhat abusive physically and had actually withheld her diabetic medications. Although she was able to try to get out of that situation, get out of the house, she still did not have access to many of the things that would allow her to participate in society. She said assistance had been offered by some people in the community, but with the payment of some sort of services that she was not comfortable with. It's a classic case of somebody who would benefit from intervention from a social worker. Those integrations in clinics and eye care facilities are not always there, but they are just incredibly useful in so many parts of eye care. Thankfully, we were able to rearrange schedules so I could devote some of my time trying to get her proper care with a social worker. She was able to get services, women's shelter, and a number of things that were able to eventually help her. But I will say, although we were able to do it, it was not efficient. It was not easy, and it was difficult to have that interprofessional relationship because it wasn't already established. I definitely recommend that easier methods of interprofessional communication help better coordinate complete care. We can think about accommodation, which was mentioned, and that is the extent to which the provider's operation is organized in ways that meet the constraints and preferences of the patient. And again, hours of operation, telephone communication, all of the above are within this category. This brings me to a Black woman that I met in her early 20s who came in for a regular eye exam. She's about 6 to 7 months pregnant, very visibly showing, and she was reporting that her vision was blurrier than before. She wasn't entirely sure why. Sometimes the hormonal changes that happen with pregnancy can cause visual changes, and sometimes refraction changes. So this wasn't something I hadn't seen before. Although when I measured her vision, I was able to get her to 20/20. When I looked at the back of her eyes critically, there was something else going on. If you look at the back in this picture, you're looking at an optic nerve. And for those who are practiced, you would know that this does not look as red and robust when it comes to the vasculature as it should. It was showing some atrophy, areas where maybe there had been blood supply that was choked off. So immediately I said to myself, you have to dilate, take a look at this patient. I dilate all my patients. However, because she was 6 to 7 months pregnant, she was uncomfortable with the dilation. Not that she was worried about the medication itself. She was worried about the ability to get home. Am I going to fall off the side of the sidewalk or be able to see or get hit by cars and crossing the street? So she said to herself, I prefer to come back on a day where somebody can accompany me and I can feel like I'm safe to get home. And I said, no problem, let's make that happen. And let's send you directly to the specialist that I know you're going to need. Sounds simple, not in practice. When it came to coordinating appointments with her OBGYN or coordinating appointments with our specialists, it was very difficult to find that time. And we were unable to see her actually for several weeks. I'm thankful that the condition that she had was an old one. It was nothing that was active. But as a provider, you're always very fearful that you're going to not catch something or miss something because you're not able to provide timely care. Finally, acceptability. Now, I wanted to definitely add this in. Acceptability, as we're reminded, captures the extent to which the client is comfortable with the more immutable characteristics of the provider and vice versa. That includes age, sex, social class, ethnicity, and the like. Now, this patient was severely impacted by the closures from COVID-19, so I definitely wanted to mention this case. And it also ties back to my first picture of my family. This is a patient in his 50s with a history of glaucoma. As we know, glaucoma is a group of diseases that affects the optic nerve, that's that round area there I'm showing, and it causes a gradual, meaningless loss of vision, peripherally initially, and eventually it can be central. If caught early and managed closely, it can be controlled to minimize vision loss in most cases. It is actually the second leading cause of blindness worldwide. And why is that? One of the main problems is unless you come in for an eye exam, until it's too late, often you're not fully aware of what's going on. Roughly 50% of the people with glaucoma do not know they have the disease. Other risk factors include age, hypertension, and a variety of other things. Race and ethnicity is a major risk factor. Glaucoma is about 6 times more likely in a Black patient than in white patients. The Los Angeles Latino Eye Study was the largest longitudinal study to provide incidence and prevalence data on the Latino Hispanic population. And it found that they're roughly twice as likely to develop glaucoma as their white counterparts. It takes an inordinate amount of communication skills to be able to tell a patient who's not having any symptoms and not experiencing anything, you have to take drops for the rest of your life, and you have to come to appointments on a regular basis. Those communication skills, it is very difficult as a provider in order to impart that to the patient. So the patient referencing in this picture had been diagnosed with glaucoma long before he saw it. And he had had eye care in about 5 to 6 years. When I saw him in 2019 in the fall, he'd been prescribed drops previously, but had been off of them for about 5 to 6 years. He had said that he was using home remedies and a variety of other methodologies in order to treat his eye disease. He was West Indian like me, so many of the interventions that he was using, I was very familiar with. And I was able to say, while that may possibly, there's a realm of possibility that that could help, this is a more efficient way, because I was very familiar with what he was doing. He had significant damage to his optic nerve, but he wasn't noticing any symptoms. So we got him back on his drops. And, you know, I don't necessarily think he got back on his drops because he saw a Black doctor, even though maybe that was a factor. I think that it was really the cultural wealth that I brought just from having a similar background, able to break things down in a way that maybe somebody else had not. So that's critically important in terms of providing adequate care for our patients. Now, this patient, unfortunately, because of the closures of our clinic, could not access care for quite some time. And when we were closed, he did have some significant eye damage from not being on drops. But I'll tell you, he got right back onto his drops after he was able to come in. And maybe some of that cultural wealth was able to help with that. So all those examples to say, I'm not a healthcare policy expert, but I can say from my clinical and personal standpoint, this is what I think may help us to get over these barriers. Continue to work on the Medicare Vision Act of 2020. This expands the coverage of eye care, and it also allows for coverage of durable materials such as glasses and contact lenses that can help people see. A lot of the visual impairment in this country is not necessarily the severe disease I showed you. Some of it is simple glasses or cataracts. I would also say expand the optometric and ophthalmological services at federally qualified health centers. At this point, data from the CDC and the Health Services Bureau show that only 3% of patients who go to these healthcare centers actually get eye care. And that's a problem of having the adequate people to staff that area, as well as having those services. As a personal plug, I would say add optometry to the eligible disciplines at the National Health Services or loan and repayment program. That's going to help to staff those areas. I do sit on the admissions committee at school here where I work. And one of the number one reasons people decide not to come to our school is the finance and the debt load. Finally, the diversification of profession will help to increase the cultural wealth and cultural competence that is necessary to reach all of our populations. And that's increasing health literacy, support for community-based outreach, as well as intentional recruitment and retention initiatives. So with that, I'll hand it back over to John, and I welcome your questions, and thank you very much for your attention.
Thank you, Dr. Harewood. That was excellent. A lot of personal insight, and it dovetails perfectly with the first presentation. Thank you very, very much. I want to use some of the remaining time for entertaining some of the questions that came in, and this will be moderated by Dr. Jennifer Coyle. Dr. Coyle is the Vision 2020. She's on the Vision 2020 Executive Committee. And for the audience, please feel free to continue submitting any questions, and we'll do our best to answer them. Thank you.
Great. Well, welcome everyone. We're really pleased you're here. And thank you, Dr. Frick and Dr. Harewood. That was an excellent summary of where we're at. And then I appreciated Dr. Harewood really bringing it home with specific examples of patients that she's seen. There's a question in the chat box that actually mirrors one that I wrote down, and I called it the if only moment. And Suzanne Gilbert asks, she refers to it as a magic wand. What barrier restriction strategies should we prioritize for the U.S. eye health sector? And I'll ask Dr. Frick first, if you wouldn't mind, wave your magic wand. If only we had A, B, or C.
I think the first place that I would go, because there's already been not everything we could do for affordability, but a lot done for affordability. The first thing that I would do is try to do a better coordination of care with the rest of the healthcare system and get the patients and the providers to understand the importance of eye health as a part of overall health. There should be clear referral systems back and forth, and get people used to thinking of eye health not just as something one goes to when you start to have vision problems, but just as a part of being a healthy individual overall.
I would answer that question that I agree. If I could have, I don't know if I could choose one, I would actually choose two, because I would try to increase the geographic access by expanding, eye care services to a lot of these community health centers. And I say that from, a practitioner's perspective, sometimes we're just so overloaded, and if we had other centers that we could send to, it would make it much easier. And also it could become, you could help to promote eye health as a part of your regular healthcare checkups if it was in these particular settings.
Excellent. So for both of you, what policies could be implemented that would address the awareness problem? Do you have any thoughts on that?
I mean, that's a really interesting question when it comes to awareness, because it's a marketing issue. And I think in the US, we are excellent at marketing a number of things. Diet Coke, lots of different things. If we can harness some of that ability and increase the health literacy of the population in a manner that people can know, that would be useful. Besides that more corporate aspect, I think that the use of community health workers and caseworkers helps to increase health literacy and helps to increase awareness in populations we might not be able to reach otherwise.
And I guess I was just going to say, I would add just one thing. I mean, I think when we think about what we teach children about health, we teach them about cardio health. We teach them about nutrition. When was the last time somebody in an elementary, middle, or high school health-related class mentioned anything about eye health? And I wouldn't want to displace other important parts of health for, public health purposes in general. But I do think there's a place from the earliest exposure to healthcare concepts to, community health workers and health messaging in adult communities to just remember, bringing people in and remembering that, this is a part of the body system that is, needs to be healthy just as much as any other part of the body system.
So I have a very specific question that I want to pose, particularly about addressing care in children. And for those of us that think of myopia, nearsightedness as a disease, I mean, I think we're reaching the point where it's the most common disease ever worldwide. And definitely the demographics and the prevalence is changing in the US. And we know that there are strategies to control myopia, and every day we learn a little bit more. Dr. Frick, could you address kind of what do you think would be, maybe even from a cost saving standpoint, of addressing eye care earlier on in an individual's lifespan, and going so far as to considering required eye exams for children, all children in the United States, as early as age 4 or 5, definitely to get them ready for school, but also to be thinking about the progression of nearsightedness and myopia?
So that's a great question. I know there's been some work done to look at the lifetime costs associated with myopia, its potential progression, and potential complications for high levels of myopia. And I think, one of the challenges that we have is, what perspective are we taking? Whose costs and whose benefits? And this is a topic that people doing health economics and health economics for policy have had to grapple with for a long time. Spending the money now to get, say, 4-year-olds screened before they enter kindergarten, $100 to $200 per screening, let's say, as a ballpark figure, for a full optometric screening. You do that for 3 to 4 million kids, you're talking about easily $500 million. And that's a cost somebody has to pay now. Where are the benefits going to come? Well, the benefits are going to come from years and decades of a change in either not seeing myopia or a slower progression of myopia and less adult complications of myopia. The challenge is those reduced complications come decades later. Who's going to save the money then? It's certainly not the same person or organization that's spending the money now. So while from a societal perspective, where we take all the costs and all the benefits into consideration, it may make an enormous amount of sense to have this focus, trying to figure out how to assign expenditures and think about later savings in a way that it actually makes sense to the people who put up the money now is a bigger challenge. And that's where this becomes as much a political question and a societal resource allocation question as it is a simple clinical and economic question.
And I would be remiss if I didn't take the opportunity to talk about other issues that we might detect in children younger. And maybe this is a question for Dr. Harewood about what you've seen just in clinical practice. I think we've all seen kids who have passed the school screening, which, quite often they're done by individuals that may not have training. We know that the ones that they're designed, they don't necessarily assess getting kids ready to learn to read. Dr. Harewood, could you perhaps address, do we need to be thinking beyond screening and think about examinations as well for kids, and covering more than just the cost of setting up a screening for the masses?
I think screenings are a good start, but if at all possible, having a complete eye exam available, even if just like you have a school counselor, you have the school optometrist or ophthalmologist there to provide a complete eye exam. Because a lot of the kids and families that we would see had a hard time coming in for their appointments. They would bring every single family member because they were not able to get eye care or to get child care, which is a huge issue. I will say, in terms of myopia control, if I can touch back on that, that was something that a lot of the time we did not even have the time to address in a hospital-based setting, because we were just trying to get a baseline level of care, So if we were able to somehow expand access in that way, so that, someone could have a point of sight examination, that would be great. The resources that would be involved, I turn that over to Dr. Frick. to answer how we would do it, but it would have an inordinate impact on our ability to take care of our kids and families.
And just to follow up on that, there's been a discussion going on in the chat as well. And, thinking about, if you were to target, or if you were to have a subset of the population rather than the full population of children being screened at once, to build on the comment that Dr. Harewood made, how do we set up an entire system? You can screen in that preschool year or that pre-K year, but then if you do target it, or if you miss a case, when do they get checked on again? Do they not get checked on for many years or until something emerges clinically in terms of how it's impacting their lives? Or do we have a system where there are regular checks, regular opportunities to catch things, and so the cost of missing something on a one-time screening is not quite as amplified as it would be, as in the case where there truly would just be one mandated screening before the child starts school. And that comes back so much to setting up an entire system of care and integrating eye care into general needs for health of the children we're talking about in this case.
So we've talked a lot about awareness and we've talked about access, and Dr. Harewood, I agree completely about continuing to expand upon the Medicare Act and including vision in it. Could one of you comment further on the need for addressing uncorrected refractive error and the societal benefit of providing refractive correction? If we do it now, what does this mean downstream for productivity, being able to provide services and being a member of society at large and contributing in a way that has an impact?
I will leave the cost part to Dr. Frick, but I will say in terms of, detecting refractive error, I think a lot of the time we're able to detect the refractive error, but the patients who come back to us who are still uncorrected, it's that they can't afford their glasses. So we're definitely talking about Medicare expansion, which is amazing in the current legislation that's put forth. But perhaps we are even talking about Medicaid expansion so that we can cover some people who may not yet qualify. Because you can get the prescription, but that has to translate to a physical pair of glasses or contact lenses. And for me, that's where I've seen the disconnect.
And just to build on that, you have the cost, and there are widely varying costs for glasses. Even in what we see advertised on television, 2 pairs for $49 or whatever the going rate is at some of the stores these days, to the ability to spend hundreds, if not $1,000 on a pair of glasses with all the special coatings and frames and all that sort of thing. So directing people to glasses that are affordable, that they want to wear, and I hate to say that fashion matters, but people need to want to wear the glasses. And it's not just much like, with COVID vaccinations, you could have the vaccines, but are they getting in people's arms? To build on Dr. Harewood's point, you can have the glasses, you can recommend the prescription, you can get them to the optician or other provider of the glasses, but you have to get them the glasses. They have to keep wearing the glasses. You can't, if you lose them or break them, how do you replace them and get those problems taken care of? All of those are things about making sure that people get and keep using the glasses. You would hope that once they see the functioning difference, that would be sufficient. But again, there's a lot of convincing of people who haven't worn glasses, in the past, and that can be a big hoop to jump through or hump to get over for people.
And from a cultural competence standpoint, some of that really is being able to tell people that certain commonly held myths, are not necessarily there. So there's a number of people who think if they wear glasses, they're going to get addicted to glasses, or that they're going to be a crutch, or that they can actually make their vision worse. And I think addressing that from a health literacy standpoint in a manner that's accessible for people to understand is critically important to providing good refractive care.
Yeah, and I think what you also touched on a little bit that came up in the chat box earlier is the whole notion of fear of visiting a doctor. And we know we see that in underdeveloped countries. Has that been an issue in your patient population, Dr. Harewood?
Absolutely. There are people, I would say specifically our younger population, who are very fearful of just coming for the first exam. Whether that's from a cultural or socioeconomic standpoint, I can't say that. I think we try to be as accessible as possible. But I'll also say that because in some communities, eye care is not integrated as part of healthcare, it seems like this extra strange thing that why am I being referred for these services? A lot of people who have the, teleretinal screenings, I know we haven't really spoken that much about that, but there are a number of people who had teleretinal screenings, at least that I saw, who ended up saying, I already had an eye exam, and were fearful that somehow they were being taken for a ride, being referred for this eye care exam. So, I think that's definitely a huge part. And there's a paper that I'm working on that looks at access to care, and fear is a huge part of what we're finding.
And I think that brings home the point that Dr. Frick mentioned at the beginning, the extra box, the extra barrier is the awareness. And I think fear plays into that. I mean, if they are aware, what do they know? So it sounds like we could go a long way in education. We can go a long way with coordination of care. We could go a long way in addressing the workforce. You both made wonderful, excellent points, and I appreciate it. So we're running over, so I'll turn it back to Dr. Barrows to finish us off in this session. Thank you both.
Thank you very much, for facilitating this part of the session here. Some of the questions came in and I can see that Kevin was also writing answers back immediately on the chat box. I hope part of that part of the IT can be recorded as well. I'm going to share my screen again for some final comments.
I'm going to go ahead and stop your video. You're sounding a little funny now. You sound, so I'm going to see if it's a bandwidth issue and see if stopping your video will help.
Are you starting me again?
No, go ahead and just keep talking. Let's see if it resolves itself.
All right. Well, this concludes our Worldside Day Congressional Briefing. We hope you take away from the presentations and discussions new information and insights on improving diversity and access that enables us to serve our constituencies and beneficiaries more effectively, better quality, and greater understanding. I want to take the last minute to thank a number of people and organizations. First, our attendees. We had approximately 55 or 60, I believe, and maybe more. Certainly our speakers, thank you both for excellent presentations. I really enjoyed it. Also the organizers of the event that include the Vision 2020 USA Executive Committee and our members shown here. I also want to thank the Oregon Health and Science University, Mitchell Briggs, who helped in a lot of this process, the biggest chair of Vision 2020 USA. Shannon Sullivan for a lot of coordination. Thank you, Shannon. The IT department. Finally, Dina Beaumont. It's very, very helpful. And again, finally, our sponsors of the Vision community that help make the event possible. Please be on the lookout for a short questionnaire we will send for your feedback and comments. In addition, a recording of the event will be posted on the Vision 2020 USA YouTube channel. Finally, although World Sight Day is one day, Vision 2020 would like to continue discussing diversity, access, and eye care throughout the year. What can we do as champions of visual health to improve what and how we address diversity and access? What can we do tomorrow, next week, next month, and next year? We will contact you soon for your ideas and continue this discussion. Thank you, everyone, and have a wonderful day.